Hi everyone, today I shall be helping you to see beyond the surface. This video presentation focuses on imaging essentials for ophthalmologists. Presenting author is Dr. SRUTHI RS. Co-authors are Dr. Marian Polly, Dr. Shebin Salim and Dr. Samvedya Vinesh. We have no financial disclosures. Though orbital imaging is never a replacement to clinical evaluation, why is it still important to us? Because it gives us better knowledge of anatomy, it helps in clinical correlation, it helps in documentation, and helps in monitoring disease progression and assessing treatment outcome. What is the role of CT scan in ophthalmology? It helps us tell the location of a lesion, extent of a lesion, effect of adjacent structures, tissue composition, diagnosis, and aids us to plan for surgeries. Common indications of CT scan in ophthalmology includes unexplained proptosis, unexplained ptosis, ophthalmoplegia, orbital foreign body, orbital trauma causing orbital fractures, orbital mass, orbital cellulitis, ocular surface or eyelid tumors with suspected orbital spread, intraocular tumors presenting with proptosis, paranasal sinus lesions causing an orbital extension, socket implant with migration. A simultaneous CT brain can be done in cases of bilateral retinoblastoma, paracellular lesions, extensive trauma, neurocysticercosis with an orbital component. Now, how do we write a CT request? It is important to highlight patient details like the patient's full name, age, a brief history of our patient, and a mention of what we are suspecting clinically and what we need in the scan. Slice thickness routinely is 2 mm cuts for orbit evaluation and 1 mm cut when it comes to orbital apex and optic nerve evaluation. Also, mention the imaging plane like axial, coronal cut, or a sagittal reconstruction. A 3-dimensional reconstruction can be requested in cases of suspected orbital fractures. A contrast enhancement can be requested in cases of vascular lesions. Soft tissue window and bone window as appropriate can also be mentioned. Now, let us look at how to read a normal CT scan. Here's the inferior axial cut showing the right globe, the infraorbital fissure, the maxillary sinus as highlighted by a red star, the nasolacrimal duct. The mid-axial cut shows the eyeball. Here's the medial rectus muscle, the superior ophthalmic fissure, optic nerve, optic foramen, and the sphenoidal sinus as highlighted by a red star. The superior axial cut here shows a lacrimal gland laterally, trochlea medially, superior ophthalmic vein crossing over, and some part of the superior rectus LPS complex here. Now, let us look at the coronal cuts from anterior to posterior, showing the globe, the lacrimal gland, the superior ophthalmic vein, the maxillary sinus, the ethmoid sinus. Posterior to the globe, we can see all the extraocular muscles very well. This is the infraorbital fissure. Here is a sagittal reconstruction which can be requested in a CT requisition, showing the superior rectus muscle, the inferior rectus muscle, the globe, and the entire length of the optic nerve from the globe till the apex. A soft tissue window helps define the details of soft tissues like muscles, globe, intraocular lens, fat, optic nerve, etc. While to see the internal architecture of the bone vividly, a bone window is required. A 3-dimensional reconstruction can be requested in cases of orbital fractures, dumbbell dermoid, orbital implant to look for migration. This is a table that shows the Hounsfield numbers corresponding to tissues. Air has the least, which is -1000 Hounsfield unit and appears black, while bone has the maximum of +1000 Hounsfield unit and appears white in a CT scan. All the rest of the tissues fall in between these parameters, with fat at -70 Hounsfield unit and water at 0 Hounsfield unit. Systematic evaluation for an ophthalmologist would start by looking at the bony orbit. Assess dimensions of the bony orbit, orbital walls, orbital apex, superior ophthalmic fissure, inferior ophthalmic fissure, optic foramen, etc. Long-standing benign tumors like pleomorphic adenoma of the lacrimal gland causes bony fossa formation, while destructive tumors like adenocystic carcinoma causes bony erosion. Next comes the eyeball. Look at the integrity of the ocular cords. Lens, look if there is any tumor inside the eyeball and rule out foreign body. Bilateral calcification with intraocular tumor suggests retinoblastoma. Nodular, hyperdense, white areas bilaterally shows optic nerve head drusense. And calcification at the insertion of the medial rectus muscle here shows a Cogan's plaque. In extraocular muscle evaluation, the size, shape, contour, thickness, margin and enhancement has to be looked for. Here are a few examples. This is a CT orbit of a patient with thyroid eye disease showing bulky muscles and a heterogeneity inside the muscles. We see that the belly is enlarged while there is relative tendon sparing. An important radiologic finding to rule out this thyroid optic neuropathy is to look at the Barrett's muscular index. What is it? It is the addition of the vertical diameter of the superior rectus and inferior rectus divided by the vertical diameter of the orbit, or addition of the medial rectus and lateral rectus divided by the horizontal diameter of the orbit. This muscular index of more than 67% is indicative of orbital apex crowding. Here's a coronal cut of a CT scan with a patient who had floor fracture. The horizontal ribbon-like normal consistency of the inferior rectus muscle is lost. It has become edematous and bulky. It looks oblong. We can see in the sagittal reconstruction that the inferior rectus dips into the maxillary sinus and comes back into the orbit through the trapdoor fracture. This is the teardrop sign. Here is a suspected parasitic cyst in a young male on the left eyebrow, and ultrasound eyelid revealed a moving live worm inside a cystic cavity which is shown in white on its circumference. MRI is usually indicated for lesions around the optic canal and orbital fissures. However, MRI has its own cons, like bony details not seen with clarity, calcific lesions being missed, and inability to be done in a metallic foreign body. A CT scan mostly remains our first line of choice. However, an MRI or an ultrasound can also be chosen based on the clinical scenario. To conclude, CT scan is an important utility in the diagnosis and management of most orbital and several ocular disorders. It is imperative for us ophthalmologists to be able to systematically and objectively interpret a CT scan and provide maximum information that can be useful in the accurate clinical diagnosis and optimum patient management. I thank you all for your patient listening.